Okay. Hi, everyone. I'm Aaron, one of the in the BMT group, and we're going to talk about amyloidosis, which can be confusing, and things have changed a little bit in the last year or two in the management, especially the role of transplant and some of the newer agents, daratumumab. I think the biggest point of confusion with the disease is actually usually within diagnosis and subtype selection. So we'll in subtype of the amyloidosis. So I'll go over kind of how I do it, and feel free to interact and ask questions at any point. Okay, so we'll go over the clinical diagnosis and clinical manifestation. We'll understand the poor prognosis of amyloidosis due to organ failure, mainly AL light chain amyloidosis. And if you're going to remember anything, it's usually on the heme board. The biggest determination of prognosis in light chain amyloidosis is what? Yeah, cardiac involvement, which we measure by BNP or pro-BNP and troponin. Those are the two biggest determinants of prognosis in amyloidosis. And then we're going to go over, and this is really being shown more, and especially some of the recent data, the importance of achieving a complete hematologic response, which is measured by the difference in free light chains, normalizing that. And then in some patients, I have a few of these patients where you'll see that they have an elevation in one of the light chains, but not much of a difference. And it's actually trying to get that absolute value of the light chain as low as possible. And then finally, the role of monoclonal antibodies in amyloidosis. And I will go over my opinion why I actually think quad therapy is now the standard of care, unlike in myeloma. And I'll go over why I would want to do 4 drugs in this disease and not in myeloma, at least my rationale for choosing that. Okay. You're not going to remember this. I just put this together. Actually, I got it from a colleague. But this just, just to remember, there's many different types of amyloidosis. The first one on the list is the most important, AL amyloidosis, and it can affect everything. But we tend to think of heart, kidneys, liver as like the big 3. And if you're going to know a few other subtypes, I think we all know AA, which is reactive amyloidosis, which they will occasionally be referred to you in your hematology clinic. And your goal is to quickly get them to a rheumatologist or an infectious disease doctor to treat the underlying cause of inflammatory amyloidosis. But it is worthy of knowing the ATTR mutant and wild type amyloidosis. One is hereditary, and then one is wild type, otherwise known as senile amyloidosis, mainly in the heart in older individuals, because that's sometimes mistaken for light chain amyloidosis. And again, when you have someone with a 75-year-old male with new onset restrictive cardiomyopathy, if you check an SPEP, right, what are the odds they're going to have an MGUS? It's going to be probably 10%. So, and then they got amyloid in their heart, but you're not done there. That would be the critical mistake, to start treating them with chemotherapy without proving it's not ATTR wild type. And then ALEC2, I don't know if we'll make it on tests yet, but I got like 10 of these in my clinic. They get referred to me. Again, this is not really the role of a hematologist, although I've taken it as kind of my role to basically educate people on the disease. It's usually seen in Hispanics, so we actually see a lot of it, and they present with kidney and liver involvement. And the ones I've seen, the kidney, I've seen, and this has actually been published in Blood, there's a series of this. People get liver biopsies for like hepatic steatosis, and they find some amyloid in it. They incidentally they find amyloid. The patient's fine, and it ends up being ALEC2. They do fine as long as they don't get kidney involvement. I have one patient in my clinic who had smoldering myeloma, and ALEC2 amyloidosis, was actually started on therapy for amyloidosis until we proved it was actually ALEC2 and not. So that again goes to the importance of accurate typing of the amyloid. This is just a picture of some of the clinical manifestations you would see. We'd like to sometimes show on boards, a thickened tongue, kind of these raccoon eyes, and you can get this wasting syndrome. Okay, and this is another little pearl that sometimes shows up with amyloidosis, especially in light chain amyloidosis. You get this acquired deficiency in factor 10. So, right, the common pathway prolongation of the PT and PTT. I've actually never seen it. There's lots of reasons to bleed in amyloid. The more common cause is actually, amyloid deposits in the vessels. They have friable vessels and they bruise a lot. Okay, but this is occasionally seen. And then, right, cardiac involvement, thickened restrictive cardiomyopathy, classically low voltage on the ECG, but not always. There's even a study showing that many patients with amyloid heart involvement have normal ECGs. Okay, and this is just taken straight from the NCCN. And anyone who's worked in my clinic, I basically copy this, and we'll go through this when we start going through treatment. But this is how we define organ involvement. Whenever I see a new light chain amyloidosis, and Dr. John can attest to this, we go through all the organs and we accurately state which organs we think are involved at diagnosis. It's like, if you don't do that, then like, yeah, that's why it's hard when I pick up referrals and this hasn't been done, because then I don't know what we started with. And this is how we define organ involvement. So I literally define all the organs that I think are involved in the patient. And then I have a baseline, and then I'm going to monitor those specific organs for responses, right? So when we treat amyloidosis, there's hematologic response, which is light chains, but then what we want to see is organ response, which can take longer after you normalize the light chains. And this is kind of how you quantify that, okay? And this, before we get into the nitty gritty, just the AL amyloidosis, the mortality remains high. The majority of patients are ineligible for transplantation, although this slide's a little dated. I argue that we don't need to do transplantation much more in amyloidosis with some of the newer drugs. A lot of the patients that I see are inpatient on the cardiology service, usually on, needing advanced heart failure support. And those patients are notoriously difficult to salvage. I will say I have 2 patients, one who got a heart transplant and is doing okay 2 years later, and another who was on the heart transplant list and with therapy did not need a heart transplant and is doing great. So, but the majority of those patients don't survive. Okay, so that was kind of just a brief introduction. So what is amyloidosis? So again, amyloidosis is not a disease, it's a collection of diseases. And it's think of the cancerous unit as the protein, not the cell. Okay, although in AL amyloidosis, it is a neoplastic cell producing the protein. So they're rare, and they're it's the classic collection of things that will make them be managed poorly. They're rare. It's confusing. There's many subtypes of disease that are managed differently, and the disease falls amongst numerous specialties in medicine, which is the recipe for disaster in patient care. So I take that us as hematologists should take ownership of this disease, even though a lot of them aren't hematologic issues. At least we can, I think it's our goal is to at least funnel them to the appropriate care team. So I see all amyloids, even if there's a question of we don't know what it is, because we can at least help define it and get them to the correct doctor for management. So again, it's a protein that's made, and for various biochemical reasons, it likes to fold into these fibrils that form these beta-pleated sheets that then deposit into tissue and cause pathology. The affected organs turn blue when stained with iodine, so it's a starch reaction, and that's where the word amyloid actually came from. Okay. These stains, just to be familiar with, because you'll see them on pathology reports. So Congo red will, it's not specific for an amyloid subtype, it's for all amyloid, right? It binds in between those beta-pleated sheets. So you'll get brick red under normal light, but when you do the polarized light is when you'll see the apple green, fluorescence. So those are the classic things that you'll hear on tests. Okay. So amyloid, you don't really need to know this, it's just for interesting sake that it's more than just the actual protein. So the fibrillary protein is the unique protein, whether it's transthyretin or light chains. And then there's this amyloid P component, which is common to all of them. Okay. So they all have this amyloid P component that combines, and then there's glycosaminoglycans that are responsible for some of the reactions it has with iodine. And there are some therapies in development that target this amyloid P component to try to degrade. There was that New England Journal paper a few years ago, although it didn't pan out to work in a randomized study, but they're working on it to try to see if they can, once it deposits, if we can target these proteins and maybe degrade them and help organ function. So protein, amyloid P, and then they have glycosaminoglycans. That's that component of amyloid. Okay. So this is for light chain amyloidosis, but for transthyretin, just skip the first 2 steps and the rest is the same, right? So you have in AL amyloidosis, you have an underlying clone of plasma cells. Now, unlike multiple myeloma, where it's a cancer, right? You have a huge clonal burden causing cancer effects, lytic bone lesions. Usually in amyloidosis, the clone's fairly small, 5 to 10%. A lot of them can just be a few percent. So it's not really a cancer, which is to its advantage. Why, if we catch this early, we can treat it really well. These cells aren't as mutated as myeloma cells. And due to really poor luck for that individual, they no longer have an MGUS. They have a monoclonal gammopathy of clinical significance, meaning the subtype amyloid, which means that the neoplastic cells produce a protein. It's a light chain. And typically lambda light chain, 90% lambdas, 10% kappas in light chain amyloidosis. And these light chains will then form these aggregates and then these fibrils, and then will deposit into target organs, heart, liver, kidney, although it really can be any organ. I have lots of patients with diffuse GI involvement. I have a poor case right now who is on the medicine service for like a year and a half with like functional bowel syndrome, getting opiates and all these things, and chronic diarrhea, and just it was finally figured out at 2 years into it, just diffuse amyloid deposition throughout they even done numerous colonoscopies, they didn't stain for it, the diffuse amyloid deposition. And she's not going to die because she doesn't have organ involvement, but she's still TPN dependent, and it's been a hard case to manage. Okay. So when you should think about amyloidosis, any of these things, but I will say that any patient that's referred to you with MGUS, myeloma, Waldenstrom's, any of those types of things, you need to at least think about it. Every MGUS, you really, I'm not asking for overdiagnosis, but every MGUS you really need, which is why MGUS referrals, although seem easy, are kind of the biggest pain in the butts, right? Because it's like a diagnosis exclusion. If you're going to do a good job on your MGUS referral, you really need to exclude all these things that could be associated with MGUS, which could be quite a big task, especially when you have a lot of records to go through. So amyloid is one of those. There's a great paper in the ASH education book from 2 years ago, which I encourage all fellows to download, monoclonal gammopathy of clinical significance. I go through that paper every time I see an MGUS to really make sure I'm not missing any of the rare monoclonal gammopathies of clinical significance. I picked up quite a few actually, but these are some of the other stuff, okay? So here's a case presentation, a 65-year-old female, diabetes, hypertension, and MGUS with a mildly elevated lambda light chain. She's seen by her hematologist yearly and has been stable. Her PCP performed routine lab work, noticed high cholesterol, high triglycerides, and proteinuria. Initially, the PCP claimed the underlying MGUS is the reason for the proteinuria, but performed a 24-hour urine collection. The 24-hour urine collection revealed 6.4 grams for 24 hours. This patient has nephrotic syndrome. The patient denied shortness of breath, dyspnea on exertion, peripheral edema, coughing, fever. So this patient with MGUS now and nephrotic syndrome, right? The differential is pretty broad, right? What could be causing the nephrotic syndrome in this patient with MGUS? What's your differential? I can't hear you. Yeah, so it could be amyloid, could be myeloma, it could be diabetic nephropathy. Hypertensive kidney disease doesn't usually cause a nephrotic syndrome. It could be light chain deposition disease. It could be any of the monoclonal gammopathies of renal significance, proliferative membranous glomerular. I have one of those, PMNIG. There's a gazillion of these things, okay? So this needs to be worked up, okay? Okay, this PCP sends the patient to nephropathy, and right, and it could be just CAS nephropathy, right? This is commonly, I like asking this question, CAS nephropathy, right, which is in overt myeloma. Those patients have nephrotic syndrome or very big proteinuria, but they don't have albuminuria, right? Because the CAS don't deposit in the glomerulus. You need glomerular screw up to get albumin to diffuse through the glomerulus to get like unlike amyloid or light chain deposition disease. So their UA will typically show no albuminuria. It could be negative. You can have a negative UA and have frank CAS nephropathy. So you really should get the 24-hour urine is what I'm trying to say. Okay. So in this particular individual, the kidney biopsy shows condoreg, mass spec, lambda, light chain amyloidosis. The nephrologist sends the patient back to hematology. Okay. There's plenty of good review articles on monoclonal gammopathies of kidney significance. I actually think we should know that really well. You'll get lots of referrals for it. It's worth knowing. Okay. So how do we work up? Any new amyloid should get a myeloma workup with a bone marrow biopsy, a karyotype, and a plasma cell FISH panel. Okay, so 1114, which is the most common translocation in amyloidosis, free light chains, pro-BNP and troponin. It's amazing. I see referrals without that. We used to get echoes. Our cardiologists here tell me to get cardiac MRIs. They like it, so I trust our cardiology service. So you got to get that 24-hour urine. And then I pull up that list from the NCCN and I specifically go through all these. I don't get colonoscopies and everything, but if I have any hesitation, I really want to accurately define organ involvement at diagnosis. Okay. So this, an M protein, I already said this earlier in the talk. How much time we got? Oh, we got time. So an M protein plus amyloid deposits on biopsy does not mean they have light chain amyloidosis, okay? The only way to prove they have light chain amyloidosis is to send the tissue for mass spec. We send it to the Mayo Clinic. You can't, I don't feel comfortable. In rare cases, I will start treatment without the mass spec back if it's super severe. And I actually have an informed consent with the patient being like, I really think this is light chain amyloid. I'm going to give you chemo. There's an off chance it's not, but I think the risks of waiting the month for this to come back, and we agree to it and we do it. So, just because, especially in older individuals, how many times you'll see an M protein and be fooled. And I've seen it now numerous times. Okay. So there's a misdiagnosis rate. And again, the misdiagnosis and there's patients out there who've probably had bone marrow transplants for not for not plasma cell related disorders. Probably many patients. Okay. This is just another slide on some of the clinical subtypes that I think we should know about. So light chain, which is the most important for us as hematologists. Secondary, which is inflammatory. So bad tuberculosis that has been untreated, rheumatoid arthritis, those types of diseases. And this is again due to the SAA protein, which is an acute phase reactant produced by the liver. So if you have chronic inflammation like Castleman's disease or any of those things, you can get this upregulation. And the only way to treat that is to treat the disease. And then senile and hereditary, it's the same protein. Okay, it's transthyretin. One is sporadically mutated in senile amyloidosis. Think of old men with heart disease. And then the other is a germline mutation in transthyretin. Neuropathy and heart disease presents in younger individuals. Okay, there's a gazillion of these subtypes, which is why you get the mass spec. And every now and then I'll get a mass spec back and I've never heard of it. And I look it up and I get to the right person. Okay. I mean, keep in mind, even Alzheimer's disease is a type of amyloidosis that's in the brain. I don't have a slide on it. I meant to add it, but sometimes you can have localized amyloidosis, localized light chain amyloidosis, typically in the dome of the bladder, in the lung. So little amyloidomas that are light chains, but they don't have systemic amyloidosis. Those patients do fine. They don't need, you need to prove they don't have systemic amyloidosis, but like the guy I have two in the bladder that were found on cystoscopies for hematuria. They just cut it out and that's all you do. Do not treat these patients for rip-roaring amyloidosis. The few I've had don't. There's reports they all have excellent prognosis and don't. There's a few papers, I went and looked this up. I have them on my computer if people are interested, that shows they don't develop light chain amyloidosis. And if they do, they had it at diagnosis. So the ones I've had have not recurred locally. This is, again, I know you're not going to remember this. I have the slides available. This is, again, the main types. And I think these first four are the ones that we should be aware of, and elect too, just because we practice here to keep in mind when treating amyloidosis. This is just a slide on mass spec how they do it. They send it to the Mayo Clinic, and it's usually covered. I don't know at the VA. What do you guys do at the VA? They send it to the Mayo. Yeah, it should be covered, and they send you. It's pretty fast actually, and they usually give you a nice little report with citations and stuff like that. So, and again, you send the actual amyloid biopsy, not the bone marrow. This is just to show one of these is low voltage, one is not, and they can both have amyloid. So don't rely just on the EKGs. Okay, just a little bit on cardiac MRI if you're not familiar with it. It's pretty good for defining amyloid, not the specific type, but it can pick up ones that are missed by echocardiogram. So again, I don't know the data behind it, but the cardiologists, at least here, much prefer this cardiac MRI than echocardiogram. I'm not going to read this. I'm just going to tell you how I work up amyloidosis. So if you suspect it, okay, what you do is you need to prove it. So you need to show amyloid deposited in tissue. Bone marrow don't count, okay? You want to show it in tissue. So I always start with a fat pad, okay? And it's like 50% of the time you'll see it in the fat pad. And at least here at UCSD, I have a nice relationship with the pathologist. I literally call them up and they come to my clinic and they do a fat pad aspirate in the clinic. I don't know what you have at the VA. I'm sure you could set that up and the pathologists love it. They love getting to see the patients and do their thing. So they do a fat pad biopsy and I have an answer in a few days. If that is negative, then I go for the least, I don't say I don't have amyloid. If it's positive, I'm done. I don't need to biopsy any other organ. I've seen that too, where like people biopsy like 5 organs. You don't need to do that. You just need to get one organ that shows amyloid. If that's negative, then I go for the least invasive organ. Basically, heart's my last choice. Well, sometimes that, I mean, the cardiologists here are pretty good. They do it with a cath and they go through, but so kidney, GI tract, or anywhere else. But you got to keep doing it until you're either sufficiently comfortable they don't have amyloidosis or until you have amyloid in tissue. Once you've found it in the tissue, you then send it for mass spec, okay? And if you've proven light chain amyloidosis, usually this is done before you've gotten your light chain back, but a bone marrow biopsy, the light chains, pro-BNP, troponin, and cytogenetics. I'm trying to think of other stuff. Those are the main thing, 24-hour urine, and that's kind of how I work it up. And as far as if it comes up back as transthyretin, you just send them to cardiology. At some places, hematology actually manages that because there are therapeutics, but here it's cardiology. There is something called a PYP scan. If there's a strong suspicion of transthyretin amyloidosis and light chain's unlikely, a cardiology usually orders this, but you can order it. I've ordered a few, and if it's called this PYP scan. It's like a nuclear scan, and if it's, I don't know exactly how it works, but if it's positive, it's very suspicious that it's transthyretin. Okay. We talked about prognostic features. So number one is the heart. Really, that's like the main thing. Heart. See, I put that a lot. And then achieving a deep hematologic response, which we'll go over. You really want to, you know, when I explain to patients, that's another thing. This is a good one to practice. You know, explaining amyloidosis to patients, if you can get your patients to understand amyloidosis, then you understand amyloidosis. So I like doing the analogy with light chain amyloidosis. You know, to think of the plasma cells as a sink that's spilling out water, and the water's going really, really fast and overflowing from the sink onto the floor, and the floor is the organs getting damaged. So, you know, our job as a hematologist is to turn off the faucet, and we do that with therapies that target the plasma cells. But it's gonna be a long discussion, especially if it's in another language, to explain this complex disease. So organ response, and again, organ response usually trails hematologic response by many months, if not years. Okay, and there's some other stuff too that is not as important to know. So everyone I see with amyloidosis, so now we're just talking about light chain, okay? I do the scoring system, and it's based off these 3 things. So the difference in the free light chain, if it's greater than 18, and then the troponin and proBNP. Pay attention to the units. Our labs report different units. I always have to go on to Google and do conversion because I can't keep it straight. But the units are different, at least here at UCSD. So pay attention to your units. It can mean quite a bit in prognosis for your patients. So I do this, that everyone with a light chain amyloidosis needs this staging, okay? And this just shows that, you know, if you're stage 4, you know, most are dead within a year. If they're stage 1, they do okay. This is with older data, but, you know, it's a very stark difference between survival. Yeah, the median overall survival is 5.8 months. It's not a pleasant discussion when you have a new stage 4 light chain amyloidosis. Okay, so now we're going to talk about treatment. We'll finish early, which is good. So what we've talked about, the goal is to have a hematologic response, which is turning off the faucet by destroying the clonal population of plasma cells. Once you do that, you'll see in the blood that the light chains go down, and then the organ response will follow, hopefully. So what are the goals of therapy? This is changing, but we know that CRs, hematologic CRs, and VGPRs are associated with improvement in survival, and you want them to be durable, okay? So this is our goal, is at least to achieve a VGPR, meaning if you do an induction therapy and all you got is a PR, you don't stop, you do something else, okay, to lower it, okay? Now, debatable is if you get a VGPR, what should you do to try to convert that to CR? There is now data that the lower the better, but then that's a risk benefit scenario with what agents you're going to use and all that stuff. But clearly, if you haven't achieved a VGPR CR, you have to keep going. Okay, so this was just a prospective observational study in patients treating with bortezomib upfront regimens, and it just shows that, you know, I'm thrilled when I get that difference-free light chain less than 10, which is even better than a CR. Those patients clearly do the best. Again, and this is amongst myeloma too, you know, escalating therapy to achieve that is that, you know, clearly if you respond to therapy, you do better, but does escalating therapy to get them to do better, does that actually improve outcomes? In myeloma, I think that's questionable, and I'll argue that till the day I die. In this disease, I think it is reasonable because it's different. It's not cancer. You know, as long as you have protein in your blood, it's depositing into tissue. So like the level of the protein in the blood truly matters, unlike myeloma, where you can have a PR after an auto and have a remission of 20 years. It's a different concept. And I get in this argument all the time with patients, doctors who treat myeloma. It's different. This disease, I think it's reasonable to treat more aggressively to get this thing as low as possible. Okay. Does that concept make sense? The responses is different in this disease. Okay. I'll skip that. I don't know. Again, this is just, yeah. So in some patients, and there is a paper for this, like I have one patient where they never had a difference in free light chain that was greater than 10, but they clearly had bad amyloid. And in that case, you use the involved. So it's, I have a lady with kappa light chain amyloid, and the kappas and lambdas were always super close. And then I just look at the involved free light chain, okay, in that particular scenario. And there is data to support that. Okay, so I'm going to talk about daratumumab now when we get to upfront therapy, but I just want to initially, usually I start with upfront therapy, but I just wanted to show the data for single agent daratumumab in the relapse. And this is why this was a big change in our treatment. So daratumumab is a monoclonal antibody for CD38, right? It's FDA approved for relapse multiple myeloma with Velcade Dex and with Revlimid Dex. It's now frontline approved Dara-Rev Dex. It's not yet approved with Dara-RVD, although it's happening. So this drug was studied in amyloidosis as a single agent. It was very effective. Unlike in myeloma, the single agent response rate is like 25, 30%, because there you're dealing with cancer. Here you're just dealing with a small clone. Daratumumab is really good as a single agent of mopping up those plasma cells and inducing responses. So this was the initial data in relapse disease. And now, you know, here's the one clinical study you need to remember from this talk, nothing else. This is the Andromeda study. This was published in the New England Journal of Medicine. This was a randomized trial of Cyborg-D. So for those who are unfamiliar with Cyborg-D, that is weekly Velcade at 1.5, Cytoxin 300 milligrams to 500, and then the dexamethasone at 40. And they added daratumumab to that and compared to Cyborg-D, okay? And they included up to 3A. They didn't include the sickest of the sick, but we still treat them with this usually. The endpoint was hematologic CR, which I think is fair in this disease because we know that hematologic CRs are associated with improvement in survival, okay? And it was better, okay? So the overall response rate was 96%, okay? And I think what was super good was that if you treat people with this, unlike with CyBorD, 82% of patients will meet your endpoint that you want, VGPR or CR. Okay, that's pretty good. Okay, and how I do it, they did it in the study of like 8 cycles and then 2 years. How I do it, especially in people with a very low burden of disease, I'm very quick to stop I'm super quick to stop the DEX. That stops pretty abruptly. I taper that off pretty fast, and then the Velcade and Cytoxin, I stop that. If after 3 cycles they're in a stringent, they're in a beautiful, your light chain's less than 10, I stop those drugs. And I continue the DARA. They did it for 2 years. I've been doing it, but that's probably overkill too. But that's how I do it. So I'm very quick. I don't just pummel them with the whole 8 cycles of CyBorD. Okay, and this just shows all these other compared to CyBorD. So 65% got their light chains less than 10. So far, everyone I've treated with it has had a light chain less than 10. I've used it now like 5 times, so I'm doing better than the study, but it's worked pretty well. FDA approved. Okay, so I ran out of time, so I didn't include the transplant stuff. So we used to treat, when I started 5 years ago on faculty, if we had a newly diagnosed amyloid, we wouldn't even treat. We would just take them to transplant if they were transplant eligible. And that's a big thing. If they have cardiac involvement that's bad, do not take these patients to transplant. They will die, okay? Keep in mind, there's one randomized clinical trial from like 20 years ago with transplant and amyloid. It was actually negative. But that being said, transplant is a one-time treatment. And because it's such a low burden of plasma cells, you can get like mega remissions with that one-time treatment. So we used to just take all newly diagnosed patients, regardless, if they were fit and eligible, we wouldn't even treat them. We would just take them straight to a transplant. Now with this regimen, though we don't have prospective data, if they achieve a light chain less than 10 after frontline therapy, I'm not transplanting them anymore and saving it. And if they achieve a VGPR, that's an area of debate. If whether you take them to transplant or not, and we don't know the right answer. And I usually would ask for help in that clinical scenario. If they don't achieve a VGPR, which I haven't had yet, then I would recommend, if eligible, for a melphalan autologous transplant. Again, eligibility is very strict in amyloidosis. These patients can do very bad with, we've had mortality just this last year with a transplant. So we're using way less transplant in the disease. All right, so relapse disease. I just, now that we're using DARA up front, I would say, I'm not going to go over that data, but I would say if we use DARA up front and they relapse, I don't see a reason not to at least try DARA again, or retrying Velcade again, as much therapy as it takes to get that light chains back down. We don't use immunomodulators as much as we do in myeloma. They can be very poorly tolerated in amyloidosis. But I'm just going to include a few other studies, things we didn't think about that are actually very effective in light chain. So Benda plus Dex has a great phase 2 study for light chain amyloidosis. And this was in a very patients who had kind of seen everything. So bendamustine can still be quite active. And again, it showed that those who achieved very good responses did much better. Okay, but it's something to think about. Okay, so novel targets for AL amyloidosis. So venetoclax. So the most common, another board question, the most common cytogenetic abnormality in amyloidosis is 1114. Okay, and we know that 1114 from the myeloma data is exquisitely sensitive to venetoclax plus proteasome inhibitors. So, and 1114 does less with Velcade on its own. So there now are case series and studies ongoing of venetoclax combinations in amyloidosis. I haven't used it yet. I would consider it in a patients who can't get a transplant. They've gone through DARA, Velcade, because it does seem to really work in the limited data sets we have. So it's something to keep in mind. Only if they're 1114. We know from myeloma in the non-11-14 that adding venetoclax actually increased death due to infections. Okay, this just shows that the venetoclax-based combinations in very refractory patients had pretty good hematologic responses, 78% VGPR-CR. So again, I haven't used it, but I could see myself using it in a situation where nothing else is available. Okay, more data that the survival was pretty good and the PFS was pretty good. 1,000 days is right, 2.5, 3 years. Okay, so this is the study ongoing of venetoclax versus investigators' choice. So we'll at least have randomized phase 2 data, hopefully supporting its use. Okay, so here's kind of the summary. If they're low risk, you could still offer auto. I think it's a discussion like auto's a one-time treatment that they could have a gazillion years of remission, but we don't know yet that you can have a gazillion years of remission with Dara-Cyborg, but we know that with 2 or 3 cycles, you can get a light chain less than 10. So I just tell my patients, like, for all we know, you'll get just as durable remission. And if it doesn't work, then we'll do the auto. So I'm not really doing auto much anymore. And again, the intermediate risk, I really manage the same, Dara-Cyborg. For high risk patients, these patients are usually hospitalized. And this would be the one time I use daratumumab in the hospital because it's super expensive. And what we've been doing here at UCSD, and these are the sickest of the sick on advanced cardiac support, we've been giving Dara-Velcade. Some have been adding the Cytoxan. It's unclear risk benefit in that scenario. And if they achieve a hematologic CR and their heart's still in horrible shape, we could do a heart transplant. Again, I've had one patient who went from needing a heart transplant to not. So we've now done, I don't know, I think maybe 7 of these. Where we, again, so if these patients, I guess, are at the VA, I think they would have to be transferred over to our center for advanced cardiac support and initiation of this. And they either, again, they all get, our group is, they're willing to transplant these patients. So and we've had some successes, okay? And then if they don't achieve at least a VGPR, then you change, okay? If they're at a VGPR, I'd have to relook. That's, I think, I haven't had that scenario up, but that would be the question is it worth trying to make them a CR with something else or a transplant? And that's up for debate, I would think, okay? And then at relapse, it's basically reusing stuff, which can be very effective. And if you've reused all that stuff, it doesn't work. IMiDs, they are hard to give in this disease, but you could try them. Bendamustine I showed you, and then venetoclax. I left off IgM amyloidosis. So if you have someone with IgM amyloidosis, look at the bone marrow. If it's plasma cells, treat it like a plasma cell problem. If it's CD20 positive lymphoplasmacytic cells, treat it like Waldenstrom's, BR, those types of things. So treat the clone, not amyloid, okay? And they've studied this. I have the papers because I had a patient with this. And again, if they're plasma cell IgM, they respond to the plasma cell stuff. If they're more B cell, then treat them like a B cell malignancy. Oh, and don't forget when you give bortezomib, like it's very, they have neuropathy, so be very careful with it. And sometimes it's not obvious they have neuropathy until you give them a little Velcade, and then they can't walk because they have horrible orthostatic hypotension. We see a lot of that. So it can be quite difficult. And then I haven't talked much about Kyprolis, right? The cardiac toxicity. And so I guess I would consider maybe using it in someone who didn't have cardiac. I haven't used it ever in this disease. So, but that's why we don't talk a lot about Kyprolis in this disease. Okay. And then how I follow these patients, what organ is involved? And again, you pull up that thing from the NCCN, it has how you quantify organ response. So you've documented the hematologic response. And in my note, I document the organ response. And you want to look for normalization for heart, you look for normalization of the BNP and pro-BNP. For kidney, you look for resolution of proteinuria. And then for liver, it's alkaline phosphatase and liver size, okay? Some supportive care that we're fortunate here that I just have these patients see cardiology, so I'm not really doing this. And they're, it's mainly diuretics occasionally, the beta blockers is no. Okay, at least for our doctors here, we don't do that. It could be deleterious, and like for like tachyarrhythmias and ventricular stuff, like pacemakers and things like that have been like cardiac resequence. That stuff hasn't been shown to be beneficial in amyloid. So it's really just diuretics is the main. I wouldn't on your own start a beta blocker without a skilled cardiologist seeing these patients. They can be very preload dependent, and they're very high risk of thrombosis. I don't prophylactically anticoagulate. Sometimes the cardiologists put them on aspirin, but once they get clots, they are anticoagulated. Okay. And then, I left out, there used to be anecdotally from real bad data, doxycycline was given to degrade the proteins. There was like series showing benefits. I stand by it, said this is stupid and it just causes pill esophagitis. They finally did a randomized study and it was negative. So there's no role for doxycycline anymore for our patients with amyloid unless they have acne. And so the goals of amyloidosis, so really that 10, the role of autologous transplant, it's kind of becoming increasingly questionable. I would say if you don't do transplant, you should refer them to a transplanter to discuss the data with them. Although, depending on who you refer them to, they might just get a transplant. So I would say if you give them daracibordine, they have a light chain less than 10, you don't need to. And then targeted therapies like venetoclax in the future. That's everything. Any questions on anything? Yes.
Last week we had a talk about maintenance therapy myeloma. Are studies looking at this, like for after the cycle, maintenance?
Well, the studies do it for 2 years. Yeah. Oh, she asked if there were roles for maintenance therapy. So the protocols, like the Andromeda protocols, 2 years. No, there's no data that doing it longer once they're in a beautiful remission. I argue it's probably not going to be beneficial because you're not dealing with a cancer. I would say I have one patient with amyloid who had like 50%, basically had myeloma, and that would be one I would treat more like myeloma and maybe push for auto. We know autos increases overall survival in myeloma. And again, I didn't talk about that. Most amyloid don't have myeloma, 10% will. And if they have myeloma, then all the rules of myeloma apply. Those patients should get transplantation. Other questions?
Yeah, thanks for a great talk. Question is, what is considered really a rule out of light chain amyloid? So if you don't have a skewed light chain ratio and your total light chains are less than 25, can you say this is not light chain amyloid? We get these people from cardiology with the abnormal MRI enhancement, and they are asking, can we send them to get the genetic testing for the ATTR?
If there's clinical suspicion for amyloid, the only way you can say it's not light chain amyloid is with a biopsy showing that it's not light chains. You can have normal light chains.
Totally normal. Okay.
Yeah, that is really the only way. So again, if cardiology sends them to you, the only way you can definitively tell them it's not that is the biopsy of the affected tissue showing some other form of amyloid. Even a marrow with plasma cells that are clonal, you still can't say it's light chain or not. That's why the importance of organ biopsy with typing is critical.
Okay, thank you.
Other questions? Yes?
As a follow-up about the maintenance question, like when these patients get autos, do you actually put them on maintenance post-auto, like in myeloma?
Yes. So the question was if we have a typical amyloid and we do a melphalan auto. So it's the same, 200 milligrams per meter squared. No, we do not do Revlimid maintenance post-auto. Yes? Yes. So if they're in CR, their light chain is less than 10, if there's some clinical judgment, but to say you got them last to 10 and it goes to now it's 15, I'll watch them for a few months. If it just stays at 15, I'm okay with it. But if it goes from 15 to 20, unlike in myeloma without CRAB, although some myeloma doctors would treat that, then I start treatment. And in those patients, now when I say I'm no expert, in the one I just did that, and a little bit of single agent daratumumab did the job, okay, and got them back into a less than 10. But yeah, you follow it. I don't do one value. I want usually at least, they're not going to die of amyloid in 3 months if you watch it. Now, clearly, if it's going to 100, 1,000, that's a different story. But I want a nice trend that's showing, hey, they're going to start getting a deposition again. Good question. Yes. So I think it's center dependent. Our cardiologist here is once you get them less than 10, not even that, they've done VGPRs, they'll just take them to transplant. Depending on their, the one patient I had a, she was 40 something, and they just took her. The second she got there, we stopped therapy, and then her heart was still bad. They didn't feel like we could wait for an organ response, and they took her. Other questions? It depends on, I think it depends on what you think you can get away with and what their comorbidities are. Some of these patients are quite ill, and relapse have mainly been using single agent daratumumab. And these are patients that I've had in the past that never got it before. But if I think I'm needing more, again, Velcade in these patients is not fun to give. But I'm usually using single agent. Unlike myeloma, you're not dealing with cancer. So, and then sometimes, relapse, depending on how they relapse, you don't always need to do a bone marrow biopsy. But if you have suspicion they've evolved to myeloma, then, all the myeloma stuff. And I typically, if the clone of plasma cells is like a few percent, I'm comfortable with a skeletal survey. But if they have like smoldering myeloma, 10 to 30%, those patients, I will get a low dose skeletal CT or a PET scan to rule out coexisting myeloma, because that does change how you manage these patients. Other questions? Do we feel better about amyloid? Good. Okay. Can I talk about yeah.